You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that had, has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health Podcast. I have a returning guest, Dr. Mark Cruz. We had a great conversation last time. We're going to be talking about airway health and specifically snoring and maybe rhinitis or stuffy noses. So, Mark, thanks for coming back. How you doing?
I'm great. Thanks for having me back. I'm doing well, and yourself?
Doing good. Yeah, I've done a number of calls since we last spoke, so I hope I'm more informed, and I'm finding areas that I see are not often discussed. So one area I wanted to bring up with you, if you don't mind, is I've spoken to a lot of practitioners, and when it comes to having a stuffy nose or a swollen nose, I found that it kills my sleep. I'll wake up 10, 20 times. My mouth will be dry. It fragments the heck out of it. And when I speak to a lot of people, they go, "Oh, well, you just have to clear your nose." But it's not that simple. So I don't know if you have any insights, techniques, ways to clear your nose, because myself, and I'm sure other people, some people I know have had stuffy noses for years, and I don't know what it's doing to their sleep and how they can clear it or affect it, but I just see it's like an overlooked issue. So I wanted to ask you what your thoughts are on it.
Sure. Absolutely. So that's really central to actually what I teach with my orthodontic partner, Barry Rayfield, who I believe you've interviewed as well. And it starts with understanding that there are 5 competencies that every mammal, every human needs, and the first one is nasal breathing. Nasal breathing is central. In fact, there is no other mammalian species on the planet that can exchange gas. That means exchange carbon dioxide for oxygen through anything other than their nose. So don't confuse a dog that's panting as gas exchange. That's heat exchange. Actual gas exchange occurs through the nose. It's only Homo sapien, modern humans, that can actually have oral tidal breathing. And the main reason for that is because we have language, and we need a relatively unstable airway to be able to phonate, to make those fine articulation sounds that create what is known as language, right? So when we go beyond just speaking and we use oral tidal breathing to exchange gas, to breathe, unless you're really huffing and puffing on the treadmill, it has some consequences to it. In fact, there are recent studies to show that 50% of children, just with nasal congestion alone, have suffer from a pro-inflammatory response. Their whole body is inflamed. So we know that nose breathing is very, very important.
Okay, and a couple of things I've noticed is I rarely have both nostrils open. I don't know if that's common or not, or if most people do have both nostrils open.
That's normal. It's defined as the nasal cycle. And so the nasal cycle has been defined as each nares alternates about every 90 minutes, where the external valve closes on one side and opens on the other. And you wouldn't notice it because the resistance in a normal patent nose, you can't really sense it unless you have either a deviated septum or swollen turbinates on one side or increased resistance on one side. Then when the good side closes, then you'll notice that you can't breathe very well. In fact, if you're in a busy day, you'll probably just transition to oral tidal breathing without even thinking about it. And then when the other good side opens, the valve opens where you can breathe through your nose, you probably won't go back to it. You won't repattern your breathing, and hence you'll have a tendency to breathe more from your mouth, and that could create again many problems. So does that make sense?
No, that's interesting. I've noticed that it switches throughout the day for me when my nose is doing well. Why does that happen?
Well, I mean, that's normal physiology. It's what we were designed, again, with the nasal cycle. And so that's why you have to have both sides patent or functioning. And in fact, the breathe rights that you see the athletes wear to enhance performance leverages that idea, because when you put these breathe rights on the external aspect of the nose, it basically opens up both valves, so you can breathe through, a bigger manifold, if you will, throughout athletic performance. And so, that's a whole rationale. There's the caudal maneuver is a way also to test that, where you kind of stretch the nares by right below the nares on your face to one side, and you'll notice it opens up the nasal passage where you have less resistance to breathing typically, unless you have very collapsible valves. But you'll be able to tell on the left and the right. In fact, you could assess function that way with this caudal maneuver.
So what do you do if your nose is stuffed up? Sometimes I've had two things happen. One, it's stuffed up, you blow it, stuff comes out, mucus comes out, and it's clear for a little while. The other one is rare, but sometimes my nose will just be swollen. Nothing comes out, it's just swollen, and that's even worse.
Right.
Because so what do you do to clear your nose if you're having a problem?
So it depends on the problem. So you described a number of different scenarios. I mean, a frank infection or inflammation, allergens because you have a lot of histamine release because there are antigens that have been introduced into the mucosa of the nose that degranulates the mucosal cells that release histamine. That's all pro-inflammatory. You get the swelling. You can have vasomotor rhinitis, which has more to do with an autonomic nervous system response. So it really depends. So if, let's say, the turbinates, which are structures in the nose on left and the right side that are designed to actually slow the flow of air, it creates turbulence to slow the air before it goes into the lungs, to condition it. It humidifies it. It brings it up to body temperature. And then it's in an environment where there's a release of nitric oxide with a sulfur center that actually is antibacterial, antiviral. It actually kills the bugs for the most part before they actually are able to enter into the lung. Another reason why you want to breathe through the nose versus mouth breathing, where it's unfiltered and it's a free pass for the bacteria and the viruses. So, but those are normal structures that can become swollen for any of a number of reasons. Just mouth breathing by itself will cause the turbinates to swell. So there are a number of different maneuvers. So again, it depends if I'm seeing a kid or an adult that has that problem. I try to rule out whether it's a structural problem, which is usually the exception, like let's say a deviated septum. And by the way, most deviated septums are not as a result of a nose fracture or fracture of the septum, because this is deeper than the external nose per se. But if you have a deviated septum through growth and development where the midline septum buckles to one side, then you're going to have a lot of resistance and be unable to breathe very easily on that side. That has to be fixed. Otherwise, if it's the rule, which is inflammation from any number of reasons, it needs to be, it should be addressed with conservative measures first. So you can use the neti pot. Everyone knows what a neti pot or a Neil med is, something that you have conditioned water that's hyposaline solution, like it has saline. You could purchase this at any CVS or Walgreens drugstore, Costco, where you put the saline in, you warm up the water, and you irrigate each nostril. Now they have these power-driven neti pots as well. And what you want to do is you want to lavage each side to clear out any of the gunk below your nose, and then keep your lips together and breathe. And, it's something that we should routinely do. And yet it's not something that we talk about very much unless we're really having a problem. But it's like I tell my patients, it's like brushing your teeth or taking a shower. You need to keep your nose clean. It is very important. We need to teach our kids how to blow their nose properly without blowing mucus into the eustachian tube. So there are ways of doing that. But the point is you don't let that naturally produced mucus that has its purpose. You don't want it to create so much resistance to breathing that now you're breathing through your mouth. So normal hygiene with a neti pot would be good. If there's still some swelling, you can go through over the counter now. You can go and purchase Nasacort, Nasonex. There are a number of different of these steroids, if you will. They're topical steroids that you can use right after you do the neti pot. But again, if you don't deal with the underlying problem, it's going to recur and you're going to become dependent on it. So you just want to use it if necessary. And if so, you use it for a very short term, a couple weeks to a few weeks. Otherwise, if it continues, then you have to have that an ENT. Typically, I would refer an ENT to have it looked at, or I'd assess it with a cone beam tomography, or you can use a speculum and look up it. Now, I'm a dentist, but I know that how we breathe through the nose also affects dental health, and that's its own discussion. I know we're not going to talk about that, but that's why I find it very important to understand that. So those are the main measures that are conservative to be able to breathe through the nose. Another one, if you have congestion, is to do what's called a controlled pause, where you basically pinch your nose and you wait until you have that response from your brainstem that says, take that next breath. And at that moment, you release the nose and then take a very, very light breath. Even though you want to bring in the air with a lot of turbulence, you want to breathe in very slowly, not with a lot of turbulence. And what that will do is it'll open up the valves, almost like you turn on a switch. You could practice it 1 or 2 times, but after a while, you'll see you can open up even when you're congested, when you have a cold or a flu with no drug at all, you could, if you know how to do it, you can open up your nasal passages and start breathing through your nose again. And so you can Google that, just do controlled pause. Buteco is another word you can use as a mesh term, and it'll pull up how to clear your nose that way. And we try to teach that to kids as well so that they're able to breathe through their nose. So those are a number of conservative measures.
Do you think it would be helpful if someone developed a lozenge that you could suck on that would release nitric oxide enough when you have to mouth breathe? Do you think that would be useful?
No, not really, because you have to understand, first of all, nitric oxide, and there's a lot of misinformation out there. You know, there are 3 physiologists, physicians, researchers that received the Nobel Prize for discovering this transient signaling molecule that's produced mostly in the nasal passages in the cilia, and that are very, very transient. And it also, you could find it throughout the endothelium lying, within the vasculature, which largely helps to dictate vascular function. So just taking it in a lozenge, it's not going to work. It's not going to work the same. The physiology is not the same. I mean, you have these super beats, these type of powders that you could put in your water to drink that elevates your energy. That has that's a different function that has to do with ATP and energy production. And there's some anecdotal evidence that there could be a benefit there. But for what I'm talking about, within the nasal capsule, no, it's not going to help nasal function per se that I know of. I've not read any credible study that actually would suggest that, and it doesn't make sense to me physiologically, quite honestly.
Well, I just figured because you're missing it if you mouth breathe. So if you replace it, what would that do? Would it help you and how?
Well, it's not that you're missing it because you're mouth breathing it. It's just that you're not producing it because you're mouth breathing. It's produced through the process of nasal breathing, where there's this light resistance that stimulates the cilia within the membrane that actually automatically releases this in nanoseconds. It lasts for nanoseconds, this transient signaling molecule. And so, we always try to come up with that magic bullet without really understanding. It's kind of like saying, an egg that is intact and with an eggshell is not an egg, that same egg that's been scrambled in a pan. I mean, the contents are exactly the same, but the way that they're structured changes materially how it's gonna function, if that makes sense. So just because you have the exact material, it has to be structured in a certain way to function physiologically the way it was intended. And so, that's why a lot of pharmaceutical interventions have what we call side effects, right? So we can get the good out of some of these chemotherapeutic interventions, but they're not exactly the way the body is intended to function. And so you have some of these side reactions that create these side effects. And so I always like to think more in organic terms. I'm not saying that's a good or bad. It's just to explain how just having a lozenge that releases nitric oxide is not necessarily going to enhance nasal function.
Okay. So what have you observed to be the short-term and the long-term consequences of someone, predominantly mouth breathing?
Oh gosh, there are volumes of studies now actually showing that in children, just if they cannot breathe through their nose 90% of the time during sleep, that it could result in growth retardation. Why? Because it is a major risk factor, as you said in the beginning, in your own words, when you can't breathe through your nose, you don't sleep very well. It perturbs sleep. And when you perturb sleep, the hypothalamus cannot release its growth hormone, the metabolic hormones, the catabolic hormones, et cetera, et cetera, et cetera. So there are now studies, as a systematic review that came out of the European literature, looking at 247 articles. They distilled it down to, I think, something like 49 articles that basically concluded that mouth breathing by itself should be considered a major risk factor for growth retardation. That's just one example. There's vascular remodeling, endothelial dysfunction. There's so many of these connections that also release IL-6, which is a pro-inflammatory cytokine. So we can go on and on with a lot of the physiology that is perturbed by not being able to breathe through the nose. And that's one of the reasons why we explain to the parent, okay, you catch a cold, a flu, fine. But when it's always the case, or the kid always has chapped lips, or that's just on the physiologic level. As it pertains to growth and development as a dentist, that is one of the main risk factors for dental crowding, because the face does not develop properly, so there's not enough arch development. And so there are a cascade of a number of problems when we don't do the very simple function of breathing through our noses. When we don't do that well, it creates lots of problems. And And the medical literature is replete with studies actually showing that. So it's not anything that's a controversy. It's same thing in dentistry as well.
Yeah, this is why I asked you about it, because when people mouth breathe, when they sleep, for instance, they're not doing it because they want to. They're doing it because I guess they have to. And why do they have to? Because, I mean, is it right to say it's because their nose is compromised? I mean, like,
well, I would,
like, what are the reasons?
Not to interrupt, but I'd argue that it's not that they want to. It's that sometimes it's a structural problem. Sometimes it's a functional problem, and sometimes it's a behavioral problem. So there are many people who can easily breathe through their nose, but they have a behavior for whatever reason to breathe through their mouth. And so behavior, to quote a good friend and world-renowned physiologist in this subject, Peter Litchfield, would say behavior is physiology in action. So you have a behavior, and there are therapies actually to repattern that. Moreover, the problem not only is with the fact that you can't breathe well through your nose when that you can't sleep well when you can't breathe through your nose, it also is a major risk factor for having what's called low end-tidal CO2. So that's the amount of reserve CO2 or carbon dioxide in your lungs, and that's measured. And every physician knows that it should be somewhere around 35 millimeters of mercury pressure of having carbon dioxide in your lungs. And I'm not going to go into all the physiology, but ultimately, that when you have it below that level, it portends toward unstable breathing. So when you're mouth breathing, you're moving a large amounts of tidal volume, and you're blowing off too much carbon dioxide, and the hemoglobin releases the oxygen to the end organ tissue as a function of that CO2 gradient, meaning that if you're overventilating, we know that you'll pass out or you'll become hysterical and it'll stimulate a fight or flight response. But if it's more nuanced, just overbreathing is just as bad as overeating. It has a big physiologic effect that, of course, also disorders your breathing at night. It's a risk factor so that's a huge discussion right there. A lot of people are in a state of chronic respiratory alkalosis, and that also causes or upregulates sympathetic drive or adrenal function. And so that's another discussion there. So that's why when people, meditate or they take yoga, they feel better because they're concentrating on the breathing. But more importantly, is their hemoglobin is easily releasing the oxygen. You're getting vasodilation, good rich blood supply to the brain, to the organs. You feel relaxed. And so we've known about that for thousands of years. And so just the simple function of breathing properly is key. And that's why we say breathing through the nose, lips together, tongue on the roof of the mouth that seals off the oral cavity to breathing. A non-collapsing pharynx during sleep and diaphragmatic breathing are the 5 competencies we want to see with our patients. When they don't do that, they're at high risk for a number of things: clenching, grinding, sleep bruxism, reflux, a lot of things that are treated as isolated symptoms without understanding oftentimes what some of the major risk factors are.
Oh, wow. Huh. This is really interesting. It's amazing all the things that are involved. It really is.
Yeah, we tend to have a mechanistic view of the body. Like, we're so hyper specialized and siloed in healthcare that I always joke how we're so specialized that we're learning more and more about less and less until we know nothing. And we lose our way in understanding the global view of how the body works. And so there are some big movements in healthcare to actually kind of step back a little bit and really understand how we're supposed to function. Because as I like to say, there's a difference between not being sick and being well. And you have to make that distinction. And our healthcare system largely panders to not being sick.
Okay, interesting. If you don't mind going back to the, not breathing through your nose, you said it's behavioral, it's structural. I forget the other terms you used. What are the percentages on? Sorry.
Functional, structural, yes. And behavioral.
What are the percentages on that? Like, what are the, if you were to look at a large sample of people, what percentage of them don't breathe through the nose because of structural problems? What percentage because of other problems? How would you break it down?
Well, I always like to use good statistics. I can only tell you that it's probably a combination. This is a huge problem. There are studies that have actually looked at breathing rates, for example, going back to the 1940s all the way through the 2000s, that have actually shown that current Western populations are breathing at a faster and faster rate. And we know that because, good old-fashioned doctor's visits used to, look at breathing rate, right, along with the blood pressure, height, weight, heart rate, et cetera. And so it's been pretty well documented as large data sets comparing decade to decade. And it's been shown that we've actually increased that breathing rate. And in part, some would suggest that it's a risk factor for why we're seeing more chronic pro-inflammatory diseases. In fact, if you look at the most recent statistics in the world from the World Health Organization of the top 10 causes of death, it's pretty staggering how about 90% of what we're dying from globally, not just in the West, are from reasons that were largely unknown just a few decades ago, what we call the non-communicable diseases. And so this is all, related to that. It's our environment that, for so many reasons, from how you're born to what you eat, to how you sleep, to how you breathe, I can go on, that's actually what's making us sick. And you probably heard on the national news about 2 weeks ago, less than 2 weeks ago, where medical science is actually stating that it's known that life expectancy has actually become shorter. And it's a trend now. It's becoming shorter. This is the first generation of children that will not outlive their parents, even though we're spending more money in healthcare than we ever have before. And it's largely for a lot of the reasons that I just mentioned, but that's large data. And so to give you a specific as to how much of it's structure, how much of it's functional, how much of it is behavioral would be just a guess. It's a combination of all. That's the other thing. Most of these problems are multifactorial. And we can't just isolate one thing. We can't be so siloed in our thinking. We have to kind of step back and look at all the risk factors.
Yeah, I totally agree. I've run into many practitioners that don't talk about any of the risk factors. They just want to give you a medication. Here, take Flonase. Bye, have a nice day. Or, let's just do surgery. So unfortunately, I think it's very rare to find someone that's willing to even think about that.
Well, there are a number of reasons. First of all, that's just part of the healthcare system. All of us, whether you're a dentist, whether you're a physician, whether you're an allied health professional, largely less so the allied health professionals, but mostly dental and medical professionals, we're all educated on disease management. The way we make our living is by getting people out of pain. It is much more difficult. It takes much more time to spend the time to garner the underlying reason. Moreover, the American public has pretty much been trained that the magic pill or that device or that, whatever it is the solution. And so if you're a healthcare practitioner, at the end of the day, in feeding your family and taking care of them, you don't want to sit around talking to the patients all day who may or may not want to hear it anyway. They just want a prescription. They just want a lab test. The system is kind of, set up to pander towards disease management. And so again, there's some big movements in healthcare that have actually realized that we have to do things differently in measuring outcomes and really focusing more on etiology, or, what's causing the problem. But, when you've got pharmaceutical companies that are spending, you go and turn on the TV, how long are those commercials? And they're constant. They're not just in the
right, yeah.
They're infomercials. It's trillions of dollars. A healthcare system, there's no money in health. There's a lot of money in sickness and in death. I mean, that's, that's just fact.
That's why I do this podcast, because I've become a health nerd, and the people listening, I don't think that they're just run-of-the-mill people. They're listening because they really want to know a lot more, and they have some problem that's either been just naysayed by a doctor or they can't fix, and it's really irking them, and they're open to, beyond the traditional type approaches. So that's like, the whole point here.
Yeah, you're right. The other part I mentioned is, again, you have a system that's very siloed. So the cardiologist doesn't speak to the urologist, doesn't speak to the pulmonologist, doesn't speak to the internal medicine. No one speaks to each other. Everyone's they'll refer out, but there's very little integration of care, because that takes time and effort. And you have different competing medical groups and so it's not a right or wrong. It's just what it is. My concern though is that it makes the internet, medicine or healthcare by the internet very easy to do, because people are looking for it, and there's a lot of misinformation, or there are a lot of agendas out there, and most people aren't educated enough to be able to filter. They may be very educated and very intelligent, but to actually filter through the evidence and understand and apprise it as to its value is difficult, and there are a lot of biases, and so I'm concerned. So for me, I try to combine the allopathic approach, which is the way I was trained, but also with taking a global holistic approach. And when I say holistic, I'm saying WH, not HO, holistic. I'm kind of stepping back and looking at the whole thing, and understand that there's more that I don't know than what I do know. And so I'm not so contemptuous to say that's not the case. I just want to ask more questions and know more. So I'm open, but I'm skeptical.
All right. Well, I did want to ask you also, if you don't mind, about snoring.
Yes.
Apnea, I've spoken a lot about,
Yes.
It's incredibly serious, but snoring, I don't know. It just seems like bypassed. From what I've read, 25% or more of couples don't sleep in the same bed. Well, they start in the same bed, and then one partner leaves during the night because someone's snoring. I've snored for years, and it's embarrassing, and mean to do it. But I wanted to talk to you about the health consequences of it. If you're a light snorer, a heavy snorer, what's going on, first of all, that cause people snoring, and then what are the health effects of it?
Well, yeah. So a number of things that you mentioned. And by the way, you sound very hypernasal. So I don't think you could breathe through your nose very well right now. I could hear it.
Yeah, I've got one nostril going, but that's it. I've had allergies lately, so
yeah. It just to be clear, it's not an accusation. It's just something I can hear. I'm really attuned to it. But so a couple of things. First of all, snoring is part and parcel of a spectrum of disorders, sleep breathing disorders, and what used to be called an innocent snore is not so innocent. In fact, we know that snoring by itself and pregnancy can have downstream fetal consequences, increased risk for preeclampsia, increased risk for gestational diabetes, increased risk for adverse birth outcomes like small for gestational age, et cetera, et cetera. So think of snoring as a collapsing airway. The reason why one snores is because the pharynx, somewhere along its length, is collapsing, and the collapsing increases the turbulence that releases this energy, if you will, that causes that tissue to flap, and our ears interpret that as that sound that we call snoring. So an individual that snores violently, for example, let's say a male that has that, we know that that's a big risk factor for carotid calcifications. So it's not so innocent. So the blood through the internal carotids that's coursing in the neck there, along where the individual is snoring, is causing precipitation of calcium out of the blood, lining the internal carotid to potentially be a life-threatening issue. So it's not so innocent. Dr. David Gozal, who's the head of physician-in-chief at Brigham and Children's Hospital in Columbia, Missouri, has actually stated on the record that snoring should never occur. We shouldn't accept it, unless you have this acute cold or flu one night or 2 nights, okay? But it shouldn't be such that a spouse is moving out of the bedroom. And yet we ignore it all the time to our demise. When you start understanding what the ramifications are, what the risks are for stroke, Alzheimer's, atrial fibrillation, arrhythmias, fatal arrhythmias, metabolic dysregulation, all kinds of problems, it's not so innocent. So we should never snore. There is no other mammalian species that snores. In fact, it's well known.
Dogs do sometimes, but
what's that?
Dogs do sometimes.
Well, yeah, they're westernized with the diets that we put them on, and we've bred them to ways where, for example, with pugs and the flat-faced canines, we've bred that into them. In fact, you talk to any veterinarian, they would say that the life expectancy of one of those breeds is directly related to how early that airway problem is resolved. And so that's called brachycephalic syndrome. Ask any vet. So we know that. Yeah, so that's not a good example. We've actually fostered that into, because it's flat-faced. Those dogs are flat-faced. They're more like humans than a collie or a German shepherd that actually has a snout, which is like most canine species. In the wild, you don't see a wolf with or a coyote. I will guarantee you they are not snoring. Homo sapiens, we did not snore just a century ago. And that's pretty well documented as well. We just didn't snore. In fact, think about it. If you're, if you're someone that's snoring out in the wild, you're food. You're ringing the dinner bell at night.
I was just thinking that, yeah, you'd alert predators.
Right, you alert predators, but also within the Indian tribes back hundreds of years ago, that's very well documented. Everyone was very quiet. The enemy would hear in the forest at night, whether if they can hear snoring off in the distance, they know they can ransack a tribe. They don't snore, and that's very well documented. So the fact that we've culturally accepted it to where now they're building a master plan homes with 2 master suites. I mean, that's how ridiculous. We don't take care of the problem. We just,
really?
We just come up with other solutions. And so that's just a cultural problem.
So, okay, with all the disorders you talked about, atrial fibrillation, metabolic problems, et cetera, I've heard that all linked to apnea. Are you saying it's all linked to snoring as well, even if a person doesn't have apnea?
Yeah, so snoring, again, it's a spectrum. So you could start snoring, and then it could progress to what's called upper airway resistance syndrome, otherwise known as inspiratory flow limitation, and then to early, moderate, and severe sleep apnea, which is an end stage. And it progresses because within the pharynx, within that airway, it's populated with nerve endings that are called mechanoreceptors. There have been over a dozen of these mechanoreceptors that have been well studied that are very sensitive to pressure, changes in pressure, changes in the patency or openness of the airway. The vibration by itself and the reflux that it engenders actually destroys those nerve endings to where now it doesn't communicate with the brainstem. And so now the muscle tone is lost. Moreover, one of the structures that's damaged early and often is the cerebellum, the right side of the cerebellum. And the cerebellum has two functions, one of which is governing muscle function throughout the body. So there's this whole cascade or a spiral of events that progresses. Probably about 5 to 7 years ago, there was a discussion as to whether, upper airway resistance syndrome was a different condition than, say, obstructive sleep apnea or snoring. And now there's enough evidence out there to actually show pretty strongly that it's all the same thing. It's just a spectrum, just like weight gain. You just gain a little bit of weight, and then 5 years later, you're actually heavy, and you just buy larger and larger waist sides, and eventually you may become obese. It didn't happen overnight. Children are rarely born obese. It's what we become. And when we become that, you could start seeing that our physiology is going to adapt and compensate, of which snoring is just a symptom.
Yeah, no, it makes total sense. So if snoring is affecting the tissues, the pharynx, that whole area, can you strengthen those tissues to stop snoring? Or
Yeah, you're right. Exactly. So again, it depends on structure and function mostly. But the Brazilians have known for much longer than we in the United States and in other parts of Europe, the whole science of myofunctional therapy. And so there are now studies in sleep medicine actually showing that myofunctional therapy actually can have a very positive effect to restoring normal function and obviating that turbulent airflow. It may not fix it completely. It depends on how progressed the condition is, but it does two things. One is it tones the various muscles that are involved in maintaining that stiffness within the pharynx, of which the tongue is one of the major aspects of it. Its number one job is it's an airway dilator muscle. Speech and deglutition or swallowing are secondary and tertiary functions. It's a main airway dilator muscle along with the diaphragm. Both must be coordinated to obviate the apnea or hypopneas that cause sleep apnea. But you can actually repattern and strengthen that by toning it. But the other part of it is you can actually, and there's studies to show you can actually repair the right side of the cerebellum, which is damaged from years of chronic intermittent hypoxia that cause part of the dysfunction with these muscles. It actually doesn't repair the old damaged neurons, but it creates new neural connections. The studies with the didgeridoo that actually does the same thing. There's studies that actually show even within a family where you have one sibling that plays the trumpet or a wind instrument and the other that plays the guitar, that the one that plays the wind instrument, they have better airway function because they're toning, those muscles in the cerebellum and how it's functioning. It's more effortless. Just like any athletic endeavor, those muscles, function similarly. So yes, to answer your question, you can, but it depends on how late in the game you're catching the problem.
Oh, okay. So as a child, sounds like a lot can be done, but what about as an adult? How much can be done? And, does it take years? Like what have you seen possible?
Typically not. So, that's a complex discussion, but I just kind of summarize to say, yes, with adults, we do it all the time. And it requires a commitment. It's like going to the gym of at least a few years, up to a few months, up to a year, depending on the specific muscle sets that are involved. They're not always involved in every patient. And by the way, you can measure that. I in my office, I measure. I like measuring everything with validated metrics to see how much the therapy is actually working versus just being very qualitative or subjective in it. So you can measure it and gain quite a bit of strength. As we always like to say, like in any muscle, it requires intensity, frequency, and duration. And it's like going to the gym. You're going to get stronger if you do several sets and you're doing it on a regular basis, and you've got pretty good intensity where you're pushing yourself to the point where not you're damaging yourself, but you're building strength, right? And so it's the same thing with any other muscle. Is a lot of people, they don't want to do it. If you have a gym membership or you have a jump rope and it just hangs in your garage, it's not going to do you much good. You actually have to use it, but it's pretty predictable.
Is there such thing as a snoring gym? Or a snoring, snoring program?
It's funny that you say that, but you hear these, at least on the West Coast, they're actually gyms that they have, how they have Zumba, they have jazzercise, and they have all these, that they'll actually have sessions where you actually working on facial muscles, which, by the way, also will help make you more youthful looking instead of sagging. And so that, yes, there's a lot that can be done. But, for the most part, the best analogy is just using myofunctional therapy, which is a structured, guided program by a properly trained therapist.
Okay, well, we're short on time, but just what's involved in myofunctional therapy? Maybe a few points that you've observed.
So, it depends on the problem. So you could have, for example, a tongue tie. It's called ankylosing, where the tongue has lost mobility and there have been compensations that needs to be addressed. But that occurs only about 20% of the time. Most of the time, it's not a structural problem like that needs to actually be released. Most of the time, it's a functional problem. And it's a number of different muscles, and there are different therapists that are licensed differently in each state that have different competencies. So you have occupational therapists, you have speech and language pathologists, also feeding therapists. You have physical therapists that have a focus on myofunction, or myofunctional therapists. So there's this general area that covers all these different therapies, of which different individuals have different subsets of knowledge that may be appropriate for a specific diagnosis. So oftentimes, an occupational therapist might be focused just on feeding. There's a problem with feeding. It takes more than a dozen muscles in very specific sequence to actually swallow without choking. And that's a problem because choking, it's the fourth leading cause of accidental death in the United States. We're the only mammal that has that problem. Or a speech and language pathologist that is dealing with a child that can't phonate, make their sibilant sounds or the fricative sounds. It's affecting their school performance. And that could be a motor problem. It could be hypotonicity in specific muscles that can be retoned. They didn't transition in their feeding. It's a huge discussion. But the point is you have a lot of different disciplines that deal with this functional aspect of the problem.
Oh, okay. Jeez. I guess the remaining question for now, even though we could have 10 more hours of discussion.
Yes.
How do you find people that are going to have this view? There's 8 million dentists out there. There's plenty of ENTs. What are some keywords people can use, or directories or something, to find these good people to work with? Not everyone can work with you. Right. So maybe let people know, how do they find these superstars?
Well, I'm working with a number of my colleagues to really change that at the level of the American Dental Association. Formally, we've actually had discussions, and there are resolutions to change that. The World Health Organization, in collaboration with the World Federation General Assembly in 2016, redefined oral health to include physiologic status, including these topics that we're talking about. So there's a global movement to trying to change our education set to treat the patient attached to the teeth rather than the teeth attached to the patient. And so I think, any terms like airway, myofunction, gosh, I'd have to really think about what terms, but I think airway health, airway function, snoring, sleep disordered breathing, those will put you in a general direction. I certainly know therapists and dentists and physicians of all stripes all over the country. We're all kind of holding hands, trying to work together to change this. Yeah, because we know the problem is huge, and no one location, no one therapist or healthcare provider can deal with the magnitude of the problem. So we must get the word out. And what you're doing right now is huge. You can't underestimate just raising awareness. It is huge. Every day I see people that come in and go, gosh, I've seen so many different healthcare providers for all these different symptoms, and they all have all these different opinions, and no one ever talked to me about my sleeping. No one ever talked to me about my snoring or about my breathing or about all those types of things. But I think that's changing in otolaryngology, ENTs, or pulmonology and sleep medicine, internal medicine. Pediatricians are starting to ask questions that they never did before.
That's good.
Yeah, I mean, this should be part of a well check, is to ask the parent about sleep tracking. The problem is most parents don't know what normal is. They figure the kid goes to sleep, they wake up, they must have slept. But there's a big difference between good sleep and poor sleep.
Yeah, what I've noticed is that, I have a project in the sleep world, which, will be outside of the podcast I'll talk to you about. But
sure.
I've noticed that people don't really think about their sleep until you ask them. And then they go, like, I've had a lot of people say, oh, yeah, I sleep pretty well. But then when you talk to them, you realize that they don't. But they don't even realize it themselves. It's just like someone that snores. You have no clue that you just snored. I've woken up and my kids go, Dad, you were snoring. I have no clue I did.
Of course.
Like, so the whole act of sleeping, it's obvious, but you're not conscious. So you're therefore not conscious about what's going on. And it's just like dreams. You wake up and then after 15, 20 minutes, it's gone for the most part. I think everything that happens during your sleep very quickly fades from your thoughts as you're awake and you get into your day. And therefore people just, if you don't sit there and think about your sleep, you'll have no clue what's going on with you. And it sounds silly because you're the one having the problem or not, but that's what I've noticed.
Yeah, no, so you're right. That's why you have to measure it. I mean, why do you go see your internist? What do is they take a blood pressure, right? They're screening for a condition that's silent, or a dentist that's, doing a periodontal probing to screen for periodontal disease. It's silent, doesn't hurt till it's in its later stages. And that's really what I'm advocating, is that the entire dental profession should be, as a frontline healthcare provider, should be screening for this very, very common problem. And more we're seeing that. In fact, I'm involved right now in an IRB, an Institutional Review Board, clinical trial with 4 clinical centers, where we're actually looking at how to objectively screen children for this problem. And so, I'm anticipating in 2020 we'll actually have our study come out, be in print. But we believe that it'll be a very good way of changing the way we practice, that we start actually screening for this this problem that is inexpensive. It doesn't hurt any more so than taking a blood pressure, and it screens for a very common problem. So we're making changes.
Yeah. Well, very good, Mark. I really appreciate your time. What's the best way for folks to get in touch with you, or to read papers you put out, or to, I guess, to ask questions?
I'm not one to promote myself. I'm pretty busy, but you could, Mark A. Cruz, MarkaCruz, D.D.S.com is my website. I actually have literally hundreds of hours of videos that you can watch from different perspectives, different individuals on this problem, different aspects of it. So I actually tell my colleagues, feel free to go onto my website and take that stuff, populate your own website. Let's spread the word. But that's one way, and you can get a hold of me. And also, I with my partner and a group of faculty, we actually teach a mini residency on how to actually manage this complex problem. And that's www.airwaycollaborative.com. That's another way of getting a hold of us. And so there are a lot of us out there that are like I say, chopping wood, just trying to get out and educate the public. And I'm appreciative of the opportunity that you've given me here and asking me to do this podcast to get the word out. So thank you for what you do.
Yeah, no problem.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.